Hello, everyone. Thank you all for joining us. My name is Tiana. I'm a clinical research coordinator here at the University of Chicago Kovler Diabetes Center.
And I am Rochelle Naylor. I am a pediatric endocrinologist, and I'm a researcher interested in atypical forms of diabetes, including monogenic diabetes. Yeah, so we'll start with, part of the reason we're doing this is February, it's Black History Month. And when we really think about all of the gains that we have made and that we need to make, gains in equity and health outcomes is one of them. And one of the areas that have a ton of disparity and unequal burden is diabetes. African Americans or Blacks are the second most affected racial and ethnic group from diabetes. The only group who has more prevalence is American Indians and Alaskan Natives. So we have about 12% of all African Americans who are living with diabetes. And not only are we more burdened in terms of the proportion of people affected, but also we are more burdened when it comes to having bad outcomes, honestly. And so it's something we need to talk about and figure out why, and really help people feel activated to partner with their healthcare providers to have, better diabetes outcomes.
Absolutely, absolutely. And so what are your gut responses when you hear these statistics, when you see these numbers? What really strikes you?
Yeah, so first let's talk about what are those numbers that we see.
Right.
So when we think about diabetes, again, African Americans are 2 times as likely to die from diabetes as non-Hispanic whites. And for those people who don't pass, there's still high disease burden. And so they are 3 times more likely to have end-stage kidney disease, where they typically will need to have dialysis or transplant. They are 2 times more likely to be hospitalized for lower limb amputations. And these are conditions that are consequences not of just having diabetes, but specifically of having diabetes that's not adequately controlled. So these are preventable complications, but only if that prevention comes early enough in the course of the condition. And so when I hear that, when I reflect on these numbers, what it tells me is we have to really get the message out to our own community that, hey, we have to be very serious about diabetes right from the beginning. We have to do whatever we need to have good control, to have our blood sugars at goal, so we can prevent the early deaths and we can prevent these complications.
Absolutely, absolutely. And just hearing those specific numbers, it makes me think about my own family, my own community, and how I do see some of these same conditions. And just thinking about my family and my friends and how it affects, the community as a whole. So it's also, I think you brought up a good point when you talked about early prevention and early treatment and the necessity of getting that message out there. I think that was a great point. Let's see if we can transition a little bit. What are your thoughts about representation in research and diabetes research in particular?
Yeah, so I'll back up to say, just like you, I have a lot of family members who are living with diabetes, and I remember growing up and watching these sort of outcomes play out in my family. And I will say that a big sometimes it feels like it's inevitable, and that is definitively a myth. So it really does come down to diabetes being adequately treated. And so there are 2 things when I think about that and how it relates to research. And that is that a lot of times African Americans are underrepresented in medical research to study the best way to treat diabetes. For instance, for the last decade or so, there's been a good insistence from the FDA that diabetes drugs need to look at cardiovascular outcomes, because people with diabetes are at increased risk for negative cardiovascular outcomes like heart attacks or strokes. And so drugs now need to look and see, are they protective? Do they help protect against that? Do they actually make it worse? Because we know there are some diabetes drugs that actually increase cardiovascular risk. And there was a study that was published in The Lancet in 2017 that looked at a number of cardiovascular outcome trials for medications treating type 2 diabetes to see did they include a diverse population of patients being studied? And specifically, when we talk about Black people, several of these studies had less than 5% of Blacks participating in the study. And some of them didn't even, kind of adequately report their racial and ethnic makeup of the participating groups, so you could really even get at that. And so one of the issues is that Blacks are really underrepresented in diabetes research of all types of medication, of technology use like insulin pumps and CGM devices. Of course, Tiana, you and I, we do research together. We know that they're underrepresented in our studies in the monogenic diabetes registry and in studies of atypical diabetes being conducted by Radiant. So it's a widespread problem, and it means that some of our best knowledge about how to prevent diabetes, how best to treat diabetes, may not actually apply the same way to Black people as it did to the study population, because Black people weren't adequately represented. So it's a issue really near and dear to my heart, because we don't want to have the population that's overburdened with the disease, overburdened with the complications, and yet underrepresented in the research to try to bring out good outcomes.
Absolutely. So from your opinion, from the facts, what are some of the causes behind this underrepresentation?
It's complex, right? So definitely it's multifactorial. So we'll talk about some of the ones that people like to talk about, right? So there has been a lot of really egregious abuse of minority populations by researchers. The one that a lot of people, I say still know, because, even the young generation knows, the Tuskegee syphilis, experiment, where researchers basically told Black men that they were giving them all of this free care, and instead they were just basically watching them die of syphilis, even though they knew the treatment. They were allowing them to spread this to their wives and affect their children. And this is one example. People are often very familiar with Henrietta Lacks, where her cells were used to create an immortal cell line that has, gone on to result in all sorts of gains in cancer research and being able to treat cancer, which is a wonderful thing, but without her actually giving permission for that to happen, and having her family have to really fight for justice around that situation. So we know those. And the reason I say we like to talk about those is because people really like to put everything on, well, Blacks are staying out of research, so then we just have to, toss up our hands and say, well, if they don't want to participate, we can't force them. But that's only a part of it. And so that is true. And it's not to be minimized, but it is not the whole story. There are other reasons that Blacks aren't participating. Some are because they're not being really asked, right? We can think we've advertised the research. Well, where did you advertise it? Did you advertise it only online? Did you advertise it at a social media site where you actually, if you looked, would know that you're not going to reach a diverse population? Like, how did you advertise your research, right? So a lot of times what ends up happening is well-meaning researchers, myself included, right? If I'm not thoughtful enough, I will, end up with a very homogeneous population because of the way that I try to get the word out about the research. Right. The other thing is, people really like to think about being equal in research, and it's important, right? It's important to equally be able to say yes or no about participating. It's important to be equally randomized to getting the study drug or getting a placebo, where it's, there's no active medication. It's important to be equal, in monitoring for adverse outcomes from participation. But people have to be much more worried about equity when it comes to making it possible for someone to participate in research. We know, for really structurally based, on purpose reasons, that being a racial minority and being in a lower SES status, these are intertwined because of systematic racism. And so it's more likely that a minority is going to have more barriers to participating in research. Can they take off of work? I'm salaried. If I miss 4 hours of work, my paycheck doesn't look different. But if I have an hourly wage and I miss 4 hours, that's a big deal. So if I don't have a car, all of these things. If I don't have daycare and I have 3 children, if I don't have daycare and can't afford it, then maybe the compensation that you're offering for my time needs to look really different for me to participate. So I think another thing that we really have to think about is equity and reducing barriers for people to participate when they want to, but they have these obstacles in the way. And I think that would do, that would really allow more people who are interested in learning more about their disease, interested in hopefully controlling it better, interested in just increasing knowledge for the good of all society, like allowing them to actually participate.
Absolutely. And I kind of want to hit on some of the points you mentioned, because you mentioned a lot of great points. But to circle back to medical mistrust, there's an awesome book that I always like to plug. It's called Medical Apartheid by Harriet Washington. And along with Tuskegee, they also just go through a lot of other historical examples of when the Black community has, received unfair treatment in medicine. And so that book is always eye-opening to me, and I think everybody should read it. And it really just shows it's not just those 2 examples, but like you said, way more that don't always get discussed. So thank you for bringing that up. And then I also want to hit on the point about, I think sometimes I agree, sometimes researchers say, oh, they just don't want to participate, when I don't think that's true. Like you said, from my experience, when I do speak to Black people who are interested in research, they say, oh, I just didn't know, or, oh, it's that simple, or, oh, I get reimbursed. Okay, cool. So I think a lot of times it's, did you actually talk to them? Did you actually reach out to them? And like you said, what are the mechanisms that we're using to actually recruit these participants? You have to meet people where they are. And I always think that's definitely key. And then another point that I always like to bring up is just education, just knowing, being fully informed about what is involved in that research really makes a difference. Yeah. So even in my experience as a coordinator, sometimes the researcher didn't explain what the study was adequately enough. And then I talk to them, I say, we're only gonna get saliva and we're only gonna look at this. And then they're like, okay, cool, like I'll definitely do it. I just didn't know. Yeah. So I think education is definitely key in that. And then you also touched on like socioeconomic status and just access to even being able to come to research visits. I think one thing that has come from this whole pandemic is virtual visits, which has helped access a ton. Because when I first started as a coordinator in like 2017, everybody had to be like in person basically. And like you said, office hours are 9 to 5, and then that's also when they're working. So how are they supposed to be able to take off for a 15-minute visit? It's just not feasible. So looking at virtual options, looking at better compensation, I think is all super important. So I'm glad you brought that up.
Well, and I was going to say, and kudos on your part, because I know that you, of course, work, around the hours that people have available to them, but that has to be part of the study design too. It can't all be, 8 to 5 or 9 to 5. There's other things, you talk about virtual, and that is a great solution, but you also have to make sure that people's computer capability and internet, there's all sorts of layers. And I think really the key is what you do, which is think about it, right? What are all the possible barriers, and can I figure out a way to mitigate them for people? Like that's the key for researchers when they're designing their study, designing their recruitment processes, thinking through what's appropriate compensation, right? You don't want to offer something that's coercive, really, right? That would maybe coax somebody to participate in something they actually aren't interested in, just because there's a line to walk, but you also need to make sure that you really are compensating adequately for time, and time is, I think, an even more precious commodity when you are a lower SES status, and you have, again, like kind of really balance hours away from work. So these are important things.
So to continue on with this point, what are some more thoughts on overall study design, and what can researchers do to build in or build in more resources to make research more accessible. And then you can speak specifically on what we do as a team or in general.
So there's you know, several best practices to think of. You know, certainly one is to think about, you know, early on just language, right? So when you're recruiting, probably at a bare minimum, you're going to want to have recruitment in we're talking US studies, in at least English and Spanish. And then depending on the population you're studying, the disease you're studying, you know, the question, the medical question, you know, obviously other languages may be important as well. But you want to, you know, that's the first start, right? It doesn't matter if I place something prominently if someone is having to read it in a you know, language that they're either not comfortable with or, you know, don't know at all. And the same thing for, you know, consent. Like, of course, you don't want to recruit in a language unless you can actually consent somebody in that language too, right? You don't want to have someone consent and to make sure they understand the study before signing on and not be certain that they really did understand all the nuances of the study. Then we talked a little bit, we talked about computer-based, right? So we do tons of things via computer. And most people really do have a computer. For most of us, it's like right here, right? It's our computer, it's our phone. But so then you want to actually know that is my website, where if I'm asking a participant to do something on the website, like, did I make sure that it was mobile friendly? That's, I think, less of an issue now than when I started on this journey. You know, I won't date myself, but more than a decade ago, I've already dated myself. You know, like there where you really had to be like, it may not pull up, you know, okay on the phone, but being mindful of those things are important. And I know that for our own registry, you know, we do have the capacity to advertise and to consent in Spanish. You know, we're very fortunate also to have a team that's diverse, including native Spanish speakers. So we can really feel confident that we're answering everybody's questions about participation. And then while we do have a web, you know, interface, we can take everything, you know, to the telephone. And so I think really having some flexibility about how people can find the study, and then also about how people can be, you know, get the information they need to decide if they want to participate, to consent. All of those things I think are really important.
And I think you touched on some great points. And one aspect that I think our team is really good with is our flexibility. So like you said, even if video doesn't work, sometimes I'm like, hey, let's do a phone call instead. Or, hey, when you go to the doctor, I can talk with the doctor if you have any questions, things of that nature. So I think our team is very flexible. And I think that does help, or that's a strength of our study as well.
One other thing I'll say, you know, and we don't specifically do this for the registry, although like you said, we're all pretty hands-on. And yeah, I've been on, you know, three-way calls with a physician and a participant in our research. But another thing to think about, depending on the type of research in the study, is, you know, community champions, really. You know, sometimes the best way to get the word out about a study in a community is from someone living in that community who can really share in the appropriate spaces. You know, sometimes that's, you know, church. Sometimes it's some social place. Other times it's like, stick your flyer here. This, you know. But I think one of the things that is really useful is working with the community, and I mean working with the community, not just going in there, you know, but like really making connections and having people be able to shape the research and the study design and all of those things so that you can be successful.
Absolutely. I read this study recently where they actually recruited community health workers that went out to specific meetings. And I felt like that was beautiful study design because it was really people in the community who were champions for the community, spoke the native language, all of that. So absolutely great point. And then I just want to close out with a few more points. Let's see, I don't think we really talked about diversity amongst the actual researchers, amongst doctors. I don't think we touched on that point. So I would like to hear your thoughts on that.
It is funny. So as they say, great minds think alike. Because right as you're saying we should close out, I was like, oh, what really, right? Exactly. So one of, you know, so there are so many benefits of diversity in all arenas. And so that includes in the healthcare professions and in the research field, right? I mean, you know, I really covet my seat at the table to say, like, I got to tell you, as a Black woman, like that, I have an issue with the language that you just told me that we're planning to do for this study, or things like that. So there really is, diversity in healthcare and in research is really critical. It's near and dear to my heart. I actually, one of the other hats I wear is as an associate program director for our pediatric residency program, and I am the director of diversity, equity, and inclusion. So I think it is really important to make sure that we are really creating pipeline programs and creating places of inclusion and support so that minorities can feel more comfortable pursuing, STEM fields. We know there's underrepresentation in research participation, there is underrepresentation in researchers, so that's another thing that we really have to address. And I think it will only improve our thoughtfulness and inclusivity in our study designs.
Absolutely. And I guess I could just speak from a coordinator perspective. I feel like there's a lack of diversity amongst coordinators as well, because I've gone to like investigator meetings and I'm like, I'm the only one here. And it's surprising because it's a great field, but I think, again, sometimes we just don't know about it and the pipeline programs aren't necessarily there. So I think, like you said, at all levels, even on the government level, even at the FDA, I would love to see more representation high up where somebody does, like you said, call it out, say, this study does not recruit enough minorities. What are you going to do about it? So I completely agree with that point. But like you said, at all levels, we need to increase representation for sure. We've had a great chat today. Are there any final thoughts that you have? Any points that you would like to touch on?
I've already said it at the beginning, but I'll say it again because I try never to miss an opportunity to remind everybody living with diabetes, the goal is to have your diabetes under control. I think a lot of times people will have as a goal, sometimes from their own providers, and yes, I'm calling out providers, right? The goal of like staying off insulin at all costs. And like, if that cost is your kidneys or your eyes, like that is a wrong goal. So I just, in my own family members, in the patients that I'm very privileged to take care of, and anybody listening, living with diabetes, remember the goal is to have good control of your diabetes. Please access the technology. The pumps help, the CGMs, the continuous glucose monitoring systems, those help. Adding a medication if your control is not good, all of these things help. And so talk to your provider. If you don't feel like you can, or your provider's not listening, find another provider and talk to them. But the goal is good diabetes control, so you are living with diabetes and still living your best life with diabetes.
Perfect. Thank you so much, Dr. Naylor.
It's always my pleasure talking to you.
Yes, it was a great conversation. And I just want to remind our audience that they can learn more about Kovler's clinical research at Kovler, that's Kovler, diabetescenter.org. So thank you so much for your time today, and feel free to reach out. Thank you.